When the client comes in and says, I have ADHD or PTSD or major depressive disorder, could you help me with that? Could you give me some tips for better managing my ADHD? How do we, as ISTDP informed clinicians and therapists, how do we approach that? The DSM diagnoses, they describe a cluster of symptoms. They're not necessarily a noun, a thing. And so it could be tempting to think of someone that has PTSD here and then another person with also PTSD, that they're one and the same. But no. People are not a monolithic block, even when they have the same diagnoses. So we don't want to fall into that trap of seeing everybody with major depressive disorder or everybody with ADHD as somehow being the same creature. Not the case. So instead, from an ISTDP perspective, we look at the underlying drivers and the underlying meaning of each person's symptoms. I was recently informed about the existence of what appears to be a brilliant psychoanalyst named Elvin Semrod. He said, investigate. And it tickles me because it's so the spirit of what we do in ISTDP in terms of the phenomenological inquiry. So someone presents with ADHD, we're going to take an interest in how are they experiencing that? What are the events that lead up to the symptom-generating moments? When are their symptoms at their height, the most intense, the most severe, the most exacerbated? When are they more in abeyance? What seems to precipitate all of that? How exactly is this unique patient experiencing what they call anxiety or what they call depression? We don't take those sort of words at face value. Instead, how are you experiencing depression? Or what does your depression look like for you, right? So we don't assume anything. We investigate. We're going for the concrete, chronological, phenomenological, experiential facts. So, Sunday, it was 3 p.m. I was in the kitchen. I was doing dishes. And the phone rang. I picked it up and I heard the voice of my sister. At that moment, this anxiety came in. My heart was going. My mind was racing. My chest and my throat got constricted. Okay? That's the level of detail. That's what we do with our inquiry. So, an example. Patient comes in and says, I have ADHD. Can you give me some tips for better managing my ADHD? The therapist here, the ISTDP-informed therapist here, could say, well, maybe I would like to try to help you, but I don't want to give you generic suggestions or generic tips. In order to make sure that whatever I offer you is really personalized for you, could we take a closer look at how you experience this ADHD so that whatever tips I offer aren't generic but are tailored to you? So true to ISTDP metapsychology, we're not going to work in the abstract. Instead, we are going to ask for specific examples, for instances, of when the ADHD symptoms were particularly exacerbated or intense. What were the events that led to the symptom-generating event or experience? So as the therapist here, you might say, I understand the concept of ADHD, thank you, but different people experience that differently. So could we look at some, for instances, some examples of when you experience it so that I can see more clearly, or together we can see more clearly, how you experience your ADHD and how that really plays out for you. So for sake of discussion, let's say hypothetically, the patient might say, sure, actually right now my mind is really racing and I'm anxious and I'm distracted and it's hard for me to focus. Like this is actually a moment when the ADHD is really off the wire. And at that point, the therapist, you can say, really, okay, I'm glad you noticed. Did you wake up this morning feeling this way? When did this begin to set in? When did it begin to ramp up for you? Oh, no, I felt fine this morning. It was actually a few hours before I came here. that I started noticing this, now that I think of it. And so there we are. We're off and running, right? We have very clinically, psychodynamically useful information at this point, right? And so again, for sake of discussion, hypothetically, let's say that the inquiry ensues, continues further, and the patient has these symptoms be exacerbated whenever they feel the need to perform, and especially around males. So with female professors, the patient is fine. But with male professors, not so much. The symptoms are there again, especially when they have to perform in one form or another. And so, as patient and therapist conduct this sort of methodical inquiry about what are the moments that lead to these symptoms, right? What leads up to it? What are the precipitating factors? If you do it properly and thoroughly, in an ideal circumstance, it doesn't always happen, but ideally, the patient will go, oh shit, this is going to be about my father, isn't it? Performing, males. My father was in and out of my life. He was never a constant. When he was around, he wanted me to perform on the piano. So what starts off with the patient saying, give me some tips for better managing my ADHD, ends up with a patient with significant psychodynamic understanding and insight into the idea that it's unresolved feelings and emotions around their father, the painful relationship with their father who was never a constant and who was in and out of their life. And when he was present, he was wanting the patient to perform, right? So you go from that to this on account of a proper and thoroughly conducted inquiry, phenomenological inquiry, where the patient and therapist work together and the therapist is patiently bringing the patient along. So that's some of the value of a proper inquiry, that the patient herself can begin to connect the dots and really see what's going on behind their symptoms. And so everyone is different. You know, this particular trajectory may not at all be the case with someone else who comes in with ADHD, right? It could be a completely different animal for that person. Today, I have talked a bit about how we as ISTDP informed therapists approach the client that comes in with a DSM diagnosis, right? The bottom line here is that we are working with and we are treating a person, a unique person at that, with a diagnosis. We're not working with diagnoses, okay? And this guy that has ADHD and this gal that has ADHD could have completely different underlying drivers. Lastly, in terms of diagnostics, not only is it important not to get too hung up on the DSM diagnoses, but for those of you that are really involved in ISTDP, there is a tendency to describe our patients like, I'm working with so-and-so and he or she's high resistance, or high resistant with isolation of affect or repression. And as convenient and helpful as it can be to have those shorthand way of referring to these categories, there's also a downside to it because from my point of view, people are more than one thing. It's much more fluid than that. People are more of a moving target. So depending on the level of pressure that's being exerted into someone's system, they might be more or less resistant. Or depending on the area of conflict that's being explored, let's say with the mother, they're not very resistant at all. But suddenly we focus on the father and there is high resistance that kicks in. So please be careful about these shorthand ways of referring to these categories. Someone could have pockets of fragility, but also pockets of ego-adaptive capacity, right? So please understand that people are more than one thing.